ectopic thyroid gland. Other features are growth is stunted, disproportionate short stature, anemia, developmental delay, delayed puberty, bradycardia, heart murmurs, and asymptomatic pericardial effusion can occur. Hormonal profile, T4 or FT4 are low, TSH are elevated, TSH is decreased in secondary or tertiary hypothyroidism. In radiological, bone age is delayed in 60% of the cases. Ultrasonography can provide information about aplasia, hypoplasia, ectopic gland, and goiter. Isotope scanning gives the information about the anatomy and site of thyroid gland, and it is usually done by technetium scan, which will provide anatomy, site, and location of the thyroid gland. This is the normal thyroid scan images, and this is the low uptake, and this is the ectopic position of the thyroid gland. Electrocardiogram show low voltage and pericardial effusion, and serum cholesterol level may be elevated. Hearing test and MRI of the pituitary gland, hearing test can be done because hypothyroidism is associated with hearing loss. MRI of the pituitary gland in case of central hypothyroidism. Levothyroxine should be started as soon as possible. Initial dose is 10 to 15 microgram per kg. Thyroxine should be given by crushing the required tablet dose with a few ml breast milk or water. Serum FT4 and TSH should be determined before the morning dose or at least 4 hours after the last levothyroxine supplementation. First follow-up visit 2 weeks after starting levothyroxine, and subsequent evaluation every 1 to 2 monthly in the first 6 months of age, and every 2 to 4 monthly between 6 months to 3 years of age, and thereafter every 3 to 6 monthly. FT4 should be maintained in the upper half of the age-specific reference range, and TSH should be maintained in the age-specific reference range 0.5 to 2 microunit per liter. FT4 and TSH should be checked 4 to 6 weeks after any change in the dose. In each follow-up, monitoring of growth, development, clinical features, and side effect of the drugs is done. Neurological follow-up and hearing test also be done. Transient hypothyroidism comprising 15 to 20% cases of primary hypothyroidism. Maternal factors contributing: antibody, Hashimoto's thyroiditis, Graves' disease, iodides. Maternal drugs contributing transient hypothyroidism are carbimazole, propylthiouracil, methimazole, and iodides. Indication of stopping levothyroxine at the age of 3 years in children with low thyroxine requirement less than 3 microgram per kg per day who meet the following criteria: absence of structural thyroid abnormality, absence of goiter, and normal neurodevelopment. Discontinuation of therapy for 3 to 4 weeks. If there is TSH elevates more than 10, then true congenital hypothyroidism and treatment should be started immediately. If the TSH is less than 10, treatment can be deferred and repeat the test, and if it is still normal, then it is transient hypothyroidism. If we start the treatment before 3 months, IQ is normal. If the start treatment is within 3 months to 6 months, there is mild treatment started beyond 6 months, there is moderate to severe mental retardation. Adequate treatment and starting treatment before 4 weeks reveals IQ at 2 years, there is no difference. Newborn screening for hypothyroidism. Screening is usually performed between 3 to 5 days of life. In this subcontinent, newborn screening is done by TSH estimation. If we measure TSH only, delayed secondary and tertiary hypothyroidism may be missed. If there is only measurement of FT4, which will miss compensated hypothyroidism. Secondary screening is indicated in case of preterm, low birth weight, very low birth weight, sick baby, and multiple birth. The goal of newborn screening is to screen within 1 week of birth and to begin treatment as early as possible. Less than 20, then follow-up should be advised. This is 11-year-old poor child having thyroid agenesis. At the time of diagnosis, weight 8.5 kg, weight for age minus 7.5 standard deviation, length 73 centimeter, length for age minus 10.5 standard deviation. Developmental age 6 to 9 months, and there is global developmental delay. So to avoid following pathetic scenario, we need early diagnosis by doing newborn screening. Acquired hypothyroidism is frequently encountered in older children and adolescents that occurs in 0.3%. Females are predominantly affected, 2:1. The most common causes of acquired hypothyroidism are chronic autoimmune thyroiditis, also known as Hashimoto's thyroiditis, endemic iodine deficiency, and some syndrome can be associated with acquired hypothyroidism, and these are Down syndrome, Turner syndrome, and Fetter syndrome. Clinical features include onset is more than 6 years, growth retardation, weight gain, goiter, cold intolerance and constipation, and bradycardia and puffiness, and there may be some skin changes can also be happen, and impaired scholastic function may be seen. Pubertal disorder, there may be delayed puberty or precocious puberty, delayed deep tendon reflexes, and there may be a muscle pseudohypertrophy. Investigation revealed thyroid profile, FT4, FT3 and TSH, and anti-thyroid antibody, anti-TPO, anti-TG antibody, and ultrasonography of the thyroid gland. Treatment of acquired hypothyroidism, levothyroxine supplementation, age-specific dose, and for any age we can give 100 microgram per meter square per day. Levothyroxine therapy should be initiated with less than half or quarter of the dose, then stepped up gradually over 3 to 6 weeks in acquired hypothyroidism. Follow-up should be done serum TSH and FT4 every 3 to 6 monthly. Chronic autoimmune thyroiditis, also known as Hashimoto's or lymphocytic thyroiditis, is the most common juvenile hypothyroidism. Girls are more common and 4 to 7 times. Positive family history is found in 25% cases, and 10% cases associated with other endocrinopathy includes type 1 DM and Addison's disease. Anti-TPO antibody and anti-TG antibody are positive in 90% cases. TSH receptor blocking antibody is positive in 18% cases, and 10% cases are non-goitrous or atrophic. A 12-year-old boy presented with excessive sleepiness, weight gain, and not gaining height for 2 years. He had coarse faces, dried up skin, disproportionate short stature, and overweight. Investigation revealed FT4 was low and TSH was high, and anti-thyroid antibody was markedly elevated. And ultrasonography of the thyroid gland revealed bilateral thyroiditis. This is the same patient after 9 months of getting treatment, and our diagnosis was autoimmune acquired hypothyroidism. Thanks for your patience hearing. Now the second part will be presented by my co-presenter, Dr. Sharmin Mahbuba.
Assalamu alaikum. On the next couple of minutes, I'm going to talk on rare cases of acquired hypothyroidism, hyperthyroidism, and other thyroid issue. A 13-year-old girl of consanguineous parents presented with a case of hypothyroidism presented with repeated oral thrush, fungal infection of nail and vaginitis since 2 years of age, and she developed alopecia totalis at 8 years of age. Investigations were suggestive of autoimmune thyroiditis, adrenal insufficiency with normal blood sugar, and parathyroid status. So it was a case of autoimmune polyendocrine syndrome 1, consisting of Addison disease, hypothyroidism, and mucocutaneous candidiasis. A 12-year-old girl presented with polyuria polydipsia and was diagnosed as a case of type 1 DM. She had thyroid swelling, and investigations revealed autoimmune hypothyroidism along with adrenal insufficiency. So it was a case of autoimmune polyendocrine syndrome 2, consisting of type 1 DM, Addison disease, and autoimmune thyroiditis. An 8-year-old male child presented with hypertrophy of calf muscles. He had athletic appearance, and thyroid function test revealed hypothyroidism. There was CPK level was raised, and there was non-specific changes on muscle biopsy. So it was a case of Cocker-Debris-Semmelweis syndrome. In long-standing uncontrolled hypothyroidism, the patients may present with precocious puberty, which is known as Van Wyk-Grumbach syndrome. And it is characterized by juvenile hypothyroidism, delayed bone age, and precocious puberty. A 3-year-old girl presented with vaginal bleeding for 10 days, pubertal status revealed breast stage 2 with absence of pubic hair and axillary hair, and the bone age was delayed. Hormone assay revealed free T4 level was low with raised TSH, FSH, LH, and estrogen level. Ultrasonogram of pelvic organ revealed relatively large uniform uterus, and there was ovarian cyst. So it was a case of Van Wyk-Grumbach syndrome. Increased hormone production by thyroid gland is known as hyperthyroidism, and the usual age of presentation is in adolescent. There is female predominance, and family history of autoimmune syndrome is found in 60% cases. Among the etiology, Graves' disease is the most common, followed by Hashimoto's thyroiditis. It may be iodine-induced, toxic adenoma, multinodular goiter, TSH secreting pituitary adenoma, and McCune-Albright syndrome. An 11-year-old boy presented with excessive sweating for 6 months and sudden weight loss for 3 months. He had heat intolerance, and on examination, there was bilateral proptosis, tremor, tachycardia, and goiter. Investigation revealed that the free T4 level was high and TSH level was low, and the thyroid receptor antibody was positive. Thyroid scan revealed enlarged thyroid gland with radiotracer concentration uniformly throughout the whole thyroid gland. So it was a case of Graves' disease. Now, what is Graves' disease? It's the most common cause of thyrotoxicosis in children due to autoimmune cause, and it consists of 10 to 15% of the childhood thyroid disease. The characteristic features include hyperthyroidism, Graves' ophthalmopathy, and dermopathy, and the dermopathy is extremely rare in children. The features of hyperthyroidism are weight loss, loose motion, heat intolerance, palpitation, goiter, tachycardia, and tremor. The investigations include free T4 and free T3 level, which is high, and TSH level is low. Anti-TPO, anti-TG antibody, and anti-TSH receptor antibody is positive. Ultrasonogram of thyroid gland and thyroid scan can be done. The first line of treatment is given by antithyroid drug, and euthyroid status is usually obtained by 6 to 8 weeks. Then tapering can be done, and the drugs can be continued up to 1 to 3 years in low dose. Withdrawal of drugs are then done gradually, and if there is relapse, drug should be restarted. The other options are beta blocker, propanolone, corticosteroid, which is used in case of ophthalmopathy, and the definitive management by radioactive iodine ablation and surgery when the medication fails. These patients sometimes present with acute emergency like thyroid storm, which is characterized by fever, tachycardia, and even congestive heart failure, some gastrointestinal symptoms like diarrhea, hepatic dysfunction, and delirium, psychosis, or even seizure and coma. The treatment can be done by antithyroid drugs, propylthiouracil, lugolciadine, beta blocker, corticosteroid, and IV fluid. A 15-year-old girl presented with high fever and swelling of thyroid gland. On examination, she was toxic, febrile, having tachycardia. Investigations revealed that TSH was undetectable with raised free T4 and free T3 level and the ALT level. She was treated with propylthiouracil, lugolciadine, propanolone, and corticosteroid along with IV fluid, and then this is our patient after recovery. So it was a case of thyroid storm. A neonate can also present with the features of hyperthyroidism. A 45-day-old male term baby presented with prominence of both eyes, irritability, less sleepiness, and loose motion since birth. Her mother was a diagnosed case of thyrotoxicosis. On examination, he was febrile, having tachycardia and bilateral exophthalmosis. Investigations revealed raised free T3 level and low TSH level. Both baby and mother's anti-TPO antibody were raised, and ultrasonogram of thyroid gland of the baby was done showing enlarged thyroid gland. So it was diagnosed as a case of neonatal thyrotoxicosis, and the baby was treated with carbimazole and propranolol for 6 months. An 8-year-old girl presented with parvaginal bleeding, which appeared at 3 years of age. Skin survey revealed multiple cafe-au-lait spots over back, and her breast stage was of stage 3 and pubic hair stage was 1. Investigations revealed markedly raised estradiol level with normal LH and FSH level. X-ray bone age was advanced, and thyroid profile revealed hyperthyroidism. Ultrasonography of pelvic organ showed enlarged uterus and enlarged ovary with multiple cysts. X-ray pelvis and CT scan of brain was done, and here we can see that polyostotic fibrous dysplasia involving the right side of the femur and frontal, occipital and left temporal bone. So it was a case of McCune-Albright syndrome. Now what is goiter? It means enlargement of thyroid gland, and it may present with it may be euthyroid, hypothyroid or hyperthyroid. Interestingly, Hashimoto's thyroiditis presents with all forms, whereas the Graves' disease present with hyperthyroidism. And organization grading of goiter, and the grading is done from 0 to 4. Among the etiology of goiter, Hashimoto's thyroiditis, Graves' disease, iodine deficiency and dysharmonogenesis are important, and also patients with thyroid nodule and malignancy may present with goiter. The investigations include thyroid function test, thyroid antibodies, that is anti-TPO, anti-TG and thyroid receptor antibody, ultrasonogram of thyroid gland, thyroid scan and FNAC. And treatment is actually done according to the thyroid status. In endemic goiter, iodine supplementation is given and goitrogens are advised to avoid. The surgical interventions are indicated in case of toxic nodular goiter, if there is respiratory difficulty, obstructive features, and if there is chance to turn to malignancy, and when the thyroid nodule size is suggestive, that is more than 4 centimeter. A 13-year-old girl presented with midline neck swelling for 4 years, and on examination she had grade 3 goiter. Ultrasonogram of thyroid gland revealed multiple nodule with cystic changes in both lobes. So it was a case of multinodular goiter. Now a few words on thyroid nodule. It is the discrete lesion within the thyroid gland, palpably or radiologically distinct from the surrounding thyroid parenchyma. And the incidence is 1 to 1.5% of children with thyroid disorders. The risk of developing malignancy is 4-fold higher in children than adults. And the risk factors for developing malignancy are age less than 20 years, single hard nodule of having size more than 1 centimeter, if there is progressive enlargement, pressure symptom, presence of lymphadenopathy and autoimmune thyroid disorders. This is an article on thyroid nodules and cancer in children and adolescents affected by autoimmune thyroiditis, where they found that thyroid nodule and thyroid cancer were 31.5% and 3% respectively among the patients with juvenile autoimmune thyroiditis. Though thyroid carcinoma is uncommon in children, it occurs in 0.55 to 3% of childhood malignancy, and there is higher rate of metastasis and recurrence, and it is thyroid gland is the frequent site of secondary neoplasm. It is classified into papillary carcinoma, follicular carcinoma, medullary carcinoma and anaplastic form. An 8-year-old boy presented with midline neck swelling for 4 months, weight loss for same duration. His thyroid profile was normal, but both anti-TPO and anti-TG antibody were positive. An ultrasonogram of thyroid gland revealed heterogeneous solid nodule in the left lobe with bilateral cervical lymphadenopathy. So FNAC was done and the cytopathology report was papillary carcinoma of thyroid. An 11-year-old girl presented with swelling of neck since birth, and the swelling moved with tongue protrusion but not with deglutition. Investigation finding revealed low free T4 level with markedly raised TSH level. And the ultrasonogram of neck showed a well-defined mixed echogenic area. FNAC was suggestive of thyroglossal duct cyst. So it was a case of hypothyroidism with thyroglossal cyst. With this, I'm ending the clinical profile of the patients with thyroid disorders. And now here are some data of thyroid disorders in BSMMU. From 2016 to May 2023, total 906 patients presented with thyroid disorders. Among them, the prevalent were congenital hypothyroid, 509, followed by acquired hypothyroid, 337, and then hyperthyroid, 51 patients. And all the hyperthyroid patients presented with goiter. And among the goiter, total 305 goiter, 9 had euthyroid, 5 patients had hypothyroidism. There were 12 patients with thyroid nodule, and among all the patients, only 1 patient was diagnosed as thyroid neoplasia. Few publications are done. Assessment of thyroid function status in transfusion-dependent thalassemia children. And the finding was frequency of hypothyroidism among these children was 10.5%. Thyroid function status of obese children in tertiary care hospital of Bangladesh. Among obese children, hypothyroidism was found in 28.9% children. And most of them had, almost all had subclinical hypothyroidism. Assessment of thyroid function and antithyroid antibodies in children with Down syndrome. Here, the thyroid dysfunction was found in 46.9% of the children with Down syndrome. Subclinical hypothyroidism was 34.5% and overt hypothyroidism was 6.2%. 6.2% presented with hyperthyroidism, and autoantibody was positive in 34.5% patients. These are the ongoing theses on etiology of common thyroid disorders in children at a tertiary care center in Bangladesh and mutation of TPO gene in children with thyroid dysharmonogenesis. Here is an article on etiology of short stature in children attending Pediatric Endocrinology Clinic of BSMMU, and they found that among the patients with short stature, the cause was hypothyroidism in 12% cases. Another article on neurodevelopmental outcome of children with congenital hypothyroidism, and they concluded that those patients who started treatment early had favorable outcome in cognitive and language domain of development. Mutation spectrum in TPO gene of Bangladeshi patients with thyroid dysharmonogenesis. The finding is sequencing-based analysis of TPO gene revealed 4 mutations in 36 diagnosed patients with thyroid dysharmonogenesis. And this is the research work on mutation of TPO and TG gene in children with congenital hypothyroidism. And the finding is 20 mutation in the exon 9 of TG gene and 4 mutation in exon 9 of TPO gene. And there is no mutation in exon 10 of TG and TPO gene. Giving importance on the thyroid disorders the World Thyroid Day has been celebrated in all countries since 2009 every year on 25th May, and this year also in Bangladesh we celebrated it, and this year's theme was "It's not you, it's your thyroid." Every year the month of January is celebrated as Thyroid Awareness Month. Aim is to educate people regarding thyroid health and its significance, and that is everybody should be tested for thyroid disorders. And the pink and blue ribbon here represents the thyroid cancer awareness. So the take-home message are, thyroid disorders are increasing among the children. Delayed diagnosis of congenital hypothyroidism may lead to moderate to severe mental retardation. Newborn screening is a must and now is in consideration of stakeholders. Education of family for technique of drug intake, importance of follow-up and compliance is needed. Genetic diagnosis of thyroid disorders are now practiced in BSMMU, and though thyroid carcinoma is rare, children with risk factors needs regular follow-up. These are our patients in BSMMU, and thank you all for your patience hearing.
Thank you, Dr. Joyashree and Dr. Sharmin Mahbooba, for your wonderful and informative presentation. Indeed, we have learned many information from their presentation. This is the time for the question answer session, and as well we have listened from the panel of experts today, from their experience, from their recommendation of this disorder. So, dear participant, please put your question, and you can write your question in your supplied pad, and our volunteers will collect this question, and I will then we will answer this question. So, and in the meantime, I will share some information. Scientific subcommittee BPA now decided to organize such type of program throughout the year in the different institute, and this is the beginning of that day, and we will today's talk on thyroid disorder, and we'll go to Kumilla on 17th of June, and in there are topics related to NewNat, that means neutral jaundice will present there, and in the succeeding month, in the month of July, we will go to Chittagong, and in this way, totally in this year, we will visit many centers with the different CME with different topics. Before reaching the question in our hand, we will initiate our panel of expert talks. For the beginning, I request Professor Nasruddin Mohammed to deliver his recommendation or information today's presentation.
Thank you, Professor Imnul. Respected chairperson of this session, my honorable teachers, colleagues, and dear students, Assalamu alaikum and a very good afternoon. I'd like to thank the two presenters. They have elaborately described about thyroid disorders, including congenital and acquired hypothyroidism, hyperthyroidism, and they have presented very nicely with appropriate case scenarios. We know thyroid disorders is very important, and it is evident that there is a thyroid day and there is a thyroid awareness month in every year. And as a physician, we know that thyroid hormones are very important for all metabolic activities, including brain growth, skeletal maturation, maintenance of basal metabolic rate, and involved in all the metabolic activities of the body. And especially we are concerned for the congenital hypothyroidism, because we know that the neurocognitive development is dependent on thyroid hormones, and growth and development of children and adolescents also depend on thyroid hormones. So due to lack of this hormone, there will be intellectual impairment, that lead to mental retardation. And we know that congenital hypothyroidism is the most common reversible cause of mental retardation. So we have to be very aware, because we need to start the treatment very early. And at very early stage, the manifestations may not be evident, as maternal thyroid hormone crosses the placenta, and it may take time. And we have seen that due to agenesis or hypoplasia or ectopic, the manifestations may start early or may start even late. So we know that in developed countries, they screen the newborns so that all cases can be captured early. We have made many developments in health sector, but still screening is not started in Bangladesh. We believe that our senior teachers, and they have link with the administration. We believe that in our country we have to pursue for screening for congenital hypothyroidism, because we see many children with even 5 years, 6 years, or even older patient come with congenital hypothyroidism, and then they were never diagnosed. So we have achieved MDG. In SDG, we have to make quality citizen, and our next generation, they should be quality, their quality should be improved to make the smart Bangladesh, which is the motto of this government. So I have very little to add, because they have described so elaborately. I don't want to take any more time. Thank you so much for giving me the opportunity. Thank you.
Thank you, Professor Naqshaduddin Ahmed, for his remarks on this presentation. I am requesting to the participant, please send your question to us. I will try to answer your question. And we know the CME is circulated in the hybrid manner. So the participant, the respected PPA member who already joined with us, please send your question in the comment box. We'll try to answer your question. Now I'm requesting Professor Fawzia Mohsin to deliver his comments on this presentation.
Respected Chairperson, Najmunahar Madam, and my respected teachers in the dais and in front of me, and my dear colleague, Assalamu Alaikum. First of all, I would like to thank BPA, the organizer, for giving me the opportunity to speak here. And I would like to congratulate both the speakers for their beautiful presentations. Actually, they have covered all the topics, so I have very little, actually there is nothing more to comment, but I will say a few specific things that we sometimes encounter in our day-to-day practice. That is, sometimes we see that in case of newborn especially, when the TSH is borderline elevated, the treatment is started. Actually, and we all know that there is age-specific reference value for the newborn. The TSH is slightly high in case of newborn. It is a normal phenomena. So in that case, we often the treatment is already started, and then the patient come to us that whether the treatment should be continued or not, and it is really a dilemma, because then suddenly stopping the thyroxine is sometimes difficult. So my request students that when we start treatment in case of newborn, we should always keep in mind a big reference value, especially for the newborn, because the TSH level, normal TSH value is much higher and sometimes higher. The TSH level is beneficial to the patient, because in that case,
And